I'm seeing the same faces. You guys are like absolute champions hanging in there. Again, in case there's any new faces, I'm Dr. Ginny Mansberg. I am a GP and menopause specialist in Australia. And so let me introduce everybody. So Olivia and Liz, who you've just been introduced to, and Masood, who you know as well. We're going to be talking about hormone replacement therapy. And I don't want to shock you all, but the four of us are probably in a different camp to some of the other opinions that you're going to hear from other doctors. And so we adhere to guidelines set down by the International Menopause Society and the British Menopause Society. And that's really quite a big difference. And we're going to probably explain a little bit about why we go in that direction as opposed to some of the more maybe creative directions around hormone replacement therapy. So, Olivia, I thought we'd start with you. Just jumping straight into the controversy. Why is that? I mean, why does the British Menopause Society and the International Menopause Society really recommend quite strongly against compounded bioidentical hormone replacement therapy? And can you explain the different types that are available and really why we would not be prescribing those compounded bioidentical hormones?
So thank you. So my name's Olivia Hum. I'm a GP and I'm one of only 240 BMS menopause specialists in the UK, and I'm also on the council of the British Menopause Society. So the British Menopause Society are the group of doctors, many of whom have been working in NHS menopause clinics for 20, 30 years. And we deliver the guidelines that most of the doctors in the UK follow and what we do is we do guidelines based on evidence. So that is how it works in the scientific world. We look at evidence and we do what is evidence-based. And so there are lots of confusion about what bioidentical HRT actually means. And there are two different things that are called bioidentical HRT. So there's what we would call body identical HRT, and that's the stuff that you can get from your NHS GP. So it's estradiol, so anyone who's on estrogel or Lenzetto on an estrogen patch, and this is body identical. It is identical to the normal hormones that your body makes. And then the other component of HRT is progesterone, and that is there to protect your womb. And there are lots of different types of progesterone or progestogen, artificial progesterone that we'll use. But what we call body identical progesterone, you may know as Utrogestan. So any of you who are on Utrogestan, this is body identical or HRT, which is identical to the normal progesterone that's produced in the body. And this is what we call regulated bioidentical HRT. It can be prescribed on the NHS, on an NHS prescription. It is derived from plants, so from yams and soy, and that's really appealing to a lot of women. But what we know is if you get 2 bottles of estrogel, the same stuff is in each one. This is regulated. It's gone through regulation and it's made in pharmacies that are regulated, so you know what's in the preparation. Compounded bioidentical HRT is a little bit different. The theory is that you can have tests that can tell what your hormones are doing, and this can be matched. The British Menopause Society would say that there was no evidence that you can do that, especially in the perimenopause, which if any of you are perimenopausal, you'll know that your hormones are fluctuating on an hourly basis. So they are going up and down and up and down. So actually what we do is we don't generally check blood tests in the perimenopause because they're just going to tell you how you are that hour, and they're not going to tell you anything about what you're going to be like tomorrow. So that's the difference. So compounded bioidentical HRT, the preparations aren't as regulated and they won't be available on an NHS prescription.
So Liz, let's talk about HRT. Why do people need it? What is it? What does it do? What's the point of it?
Okay, so HRT is basically the umbrella term for all types of hormone therapy replacement. And there are all different types and different ingredients. And, some you might find are transdermal. As Olivia just said, there's the bioidentical and then the compounded ones, which are not endorsed by the British Menopause Society. HRT is usually prescribed to help with your menopausal symptoms. So those are like hot flushes, night sweats, but it can also be mood swings. It can be for low libido, but these are just a few of the many symptoms.
Fantastic. So I don't know how many of you are taking HRT, But if you go to your local NHS GP and you have high blood pressure, we are all over that. It is so easy. There's a really simple algorithm. I often describe prescribing HRT, it's a little bit more like an art because everybody is a little bit different and responds a little bit differently. And so a lot of women say, I tried HRT, it wasn't for me. Masood, I thought I'd ask you, what are some of the common problems that women encounter when they try HRT for the first time? And I'm thinking about things like breast tenderness or bleeding, unscheduled bleeding, and how do you approach that and how do you tailor the preparations for the woman in front of you?
Yeah, I think I would say that HRT on the whole is very safe, effective treatment. It's usually tolerated very well, but you will encounter potential problems and some women will get side effects. It's very important that when patients are treated that you pre-warn them as to what to expect, the potential benefits and side effects. And some women will get some side effects initially with treatment, whether that be breast tenderness. Bleeding is a potential issue, particularly if someone under the age of 51 and they're still having some degree of menstrual cycle. I think it's important to choose the right therapy. We quite often will use sequential therapy under those circumstances. In a woman who then potentially goes on to continuous combined therapy, it's often we would pre-warn the patients that they may get some breakthrough bleeding and that's to be expected. I think there are certain warning signs to give to patients that if they get bleeding which is out of context to their normal pattern or the bleeding continues beyond 6 months, then they need appropriate assessment by a specialist to make sure that they haven't come to any harm. But I think on the whole, HRT therapies are very safe and effective. It's really important to tailor the treatment to the individual. Some women tolerate certain HRTs better than others, and I think on the whole, I think many specialists would opt for transdermal preparations because of no significant systemic side effects. But I think you've got to tailor the treatment to the patient. We do have so many HRT preparations available, whether it be transdermal, oral, intrauterine preparations. There's a lot of preparations available, and you've just got to find the right treatment for the patient.
Yeah, absolutely. And just if anyone here has got migraines, particularly with an aura, do you know when you can see a fuzzy line before you got your migraines coming on, you cannot have tablets. You have to have it on your skin if you're going to take estrogen. So as Masood was saying, there are transdermal preparations. So they come in sprays and gels and patches. And the other people who we would really not encourage to take a tablet of estrogen are women who've had what we call an unprovoked clot. So if you had hip surgery and then got a clot on the side of your hip that you've had hip surgery on or knee surgery, that's a provoked clot. We kind of almost expect that, but if one just came randomly, we would prefer that you would have, you can still have HRT, but it would go over your skin. Olivia, I just thought I'd come back to you, and if anyone has read a paper in the UK in the last year, you'll know that there's been a bit of controversy around what is the highest dose of estrogen someone can and should be on. Now, there are a lot of women who are either looking on TikTok and going up and up and up with their doses of estrogen to control their symptoms, or they might have even had some advice from a doctor to go up into higher doses of estrogen. I just thought, Olivia, you could walk us through why that has been quite controversial here in the UK, also in Australia, where I'm from, and what the concerns are about just going up and up and up a dose with estrogen.
So I think this has been a massive form of controversy in the medical community, and so essentially the basics, the way that HRT works is you have estrogen to control your symptoms, and you have progesterone which protects your womb lining from the estrogen. And we know that if we give women estrogen on its own, then what will happen if you have a womb is that the womb lining will grow and grow and grow. And the problem is with that is that can lead to womb cancer. And in the early days of HRT in the 60s, when they were just giving women estrogen, this is what happened. So you need progesterone. And what we have is that we know that up to 4 pumps of estrogel or an 100 microgram patch, we know that we know the progesterone levels that are necessary to protect the womb. Once we go up above that, we just don't know. And the problem is with that is that we're really worried. We're now seeing women on enormous doses of estrogen, 16 pumps of estrogel, and you must be seeing this too, 400 pumps, micrograms of estradiol. And what happens then is that we're really worried is that what we're going to see in 3 or 4 years' time is that these women start developing abnormal thickening of the womb lining. And it's really difficult because for some women, they do feel that they want a higher dose or need a higher dose. But what we also need to really remember is that not all symptoms that happen in your 40s and 50s are menopausal. So your 40s and 50s are a really, really tough time. I mean, I'm 49, I can absolutely know I've got kids, I've got a job, I've got elderly parents, I've got everything else that all of you guys are having to deal with. And it's very tempting to think this is all going to be solved by just increasing my HRT more and more and more. But actually, and this is what we do at my clinic, it's just about looking holistically at everything that's going on in your life. And so what we concern, and actually as Ginny said, don't be increasing things without talking to people. But what we're concerned, and the reason that the British Menopause Society has issued a safety alert to doctors, is that what we're concerned about is that in a few years' time we're going to see a big epidemic suddenly of women developing abnormal womb lining thickening because of their estrogen, and the evidence just isn't there, and we don't know what the evidence is, and that's what's so difficult for women.
Absolutely. I don't want anyone to panic if any of you are on a higher dose of estrogen than that 100 patch or the 4 pumps of estrogel. I don't want you to worry about it, but it is worth having a chat to your doctor. Just to reassure you, there was just a very big paper that was presented at the Australasian Menopause Society meeting where they found that if you're not bleeding vaginally, there is no chance that you have cancer. So we're not going to accidentally miss it. At the same time, as Masood was saying, if early on when you're starting HRT you do get a bit of bleeding, we're not going to panic too much. But if you have not been bleeding for 6 or 8 months and all of a sudden you do start bleeding, that is straight back to your doctor immediately, because we do need to know about that. Liz, just
to the question of the risks with the high estrogen, I think it's worth mentioning that if you are getting high doses of estrogen, the body stops reacting to it, and there's a medical term called tachyphylaxis. So where when you then try to reduce it, you are troubled by menopausal symptoms. So that's why we're trying to not go above the recommended guidelines. So it can actually be a risk to you.
And the other thing, you're absolutely right, is that it can actually cause symptoms. So I not uncommonly in my clinic see women who are saying, I'm getting symptoms, it must be because I don't have enough estrogen, and actually they've got too much. And so they're starting to get symptoms, they get palpitations, their heart races, they get headaches, and actually they're on too much estrogen rather than too little. And so what we're saying, if you are on a higher dose, what we will do now is we'll increase your progesterone. So if your womb lining's just to stop your womb lining being thickening. So again, many GPs now, if you're on a higher dose of estrogen, they'll be increasing your progesterone in order to protect your womb lining from the estrogen. So do go and ask if that's something that you're concerned about.
Absolutely. Let's talk, Liz, about coming off HRT, because a lot of people get started on hormone replacement therapy for troubling symptoms and then have got no idea how and when to come off it. What are your general principles?
Okay, so in the past, some doctors recommended to stop the HRT after 5 years, but I think we have all moved on from that. And whenever you come to a follow-up with the doctor, you should establish what is the HRT giving me in terms of benefits, what does it do for my quality of life, and you should have a discussion about the risks. Yeah. So if the benefits outweigh the risks, then we don't put arbitrary limits on how long you can be on HRT.
That's really important that you guys know that, because I get asked all the time, it's been 5 years, do I need to stop it now? Or I see patients who've been taken off it because it's been 5 years. You do not need to. At the same time, you don't need to stay on it either. If you wish to come off it, that's totally fine. What I would personally do is I wouldn't go cold turkey. I would probably, if you're on a patch, I'd ask for a lower dose of patch next time you're seeing your GP, or if you're on estrogel, you might want to halve the number of pumps that you're on just to sort of come off it slowly, just to see what happens, because you don't know whether you're going to be one of that 20% of people that are still flushing into your 60s and 70s. You don't know until you come off it. So if you want to, that's totally fine, but please do it with your doctor.
And Jenny, can I add something? So if you are considering coming off it, a question I get often asked is, will I get symptoms when I get off the HRT? And I don't know. I would like you to imagine the menopausal symptoms like a wave. So you're standing on the beach and you see a big wave, and the HRT helps you to dive through it. But then at the end of that, it could either be a flat sea, or you might get another wave of menopausal symptoms when you come off the HRT. And I don't know what type of patient you are. Some people come off the HRT really easily, and some might get hot flushes and the night sweats again.
Yeah, we think menopausal symptoms last, don't they, for an average of about 5 to 10 years. But that's an average. So for some women, they literally have no, remember, 10% of women have no symptoms at all. Some women will have symptoms for a few years, others they'll go on for 10 years, and some, as Jenny was saying, for even more. So we don't know. What it's doing is it's masking your symptoms. It's not delaying the menopause, which is what we used to think. It's just masking your menopausal symptoms. So when you come off, you might, as Liz said, you might have got out to that calm sea and be fine, or you might find that all your symptoms have come back again. But the important thing to say is the HRT has not influenced that. The time that your symptoms last for is predetermined. It's nothing to do with whether you take HRT or not. So you are not altering that process. You're just masking it, which is a good thing if that's what's right for you.
Such great advice. So Masood, a lot of the people who are sitting here today are thinking about maybe making an appointment with a doctor, or they have an appointment with an NHS doctor. And you might be lucky enough to get 7 minutes with that NHS doctor, unfortunately, on the first time you walk in. So what advice would you give to the women who are here, who are thinking about they're going to have an appointment with a doctor? It's really good to get organised and go in to quick and snappy. What would you put in your wish list of for women who are coming to see you at an NHS clinic?
You know, I think the most important thing first is making sure women seek help and advice. Don't be scared or apprehensive. We've had studies good 10, 15 years ago, which unfortunately did scare a lot of patients as to the potential risk with HRT. On the whole, HRT is extremely safe, very effective, can significantly improve the quality of life of many tens of thousands of patients. So I think the most important thing is make sure that you do approach your GP first. I would hope that with these larger GP practices, there's at least one or two GPs who have a particular interest in hormone replacement therapy. If they don't have that interest, then a GP could always refer you to a local HRT or menopause clinic. My colleague was mentioning that we've only got 140 advanced menopause specialists in the country, but hopefully with further education and training, we will have more. We'll have more GPs, more specialists that do more dedicated training, because there's a significant demand. There's millions of potential patients who need HRT therapy, and it's really important that they have access to high quality care.
So true. I'm going to ask for your questions in a moment. So Chloe's got the microphone. You've got 3 top experts here. Don't miss your opportunity to ask them your questions. While I'm waiting for a show of hands, Olivia, you train a lot of these GPs who are the local GPs of people who are here today. And you've seen a big difference over the last 5 years. I think there's a lot of panning of GPs, but you have not found that.
I really find so. I mean, definitely, I think 3 years ago, what you've got to remember when this all happened, when the Davina McCall documentary suddenly blew everything up, it was firstly still during COVID, but also as you were mentioning, we'd been told for decades that HRT was dangerous, that we couldn't give it to women because it was going to give them cancer. And we genuinely, even as a female GP who did specialise in menopause, I probably saw one woman a month for HRT, and I went very suddenly to seeing 10 women a day, and that was how busy it suddenly got. And so for GPs, there's been an enormous learning curve, and what's really brilliant is that me and Zoe Shadell, who's my other GP specialist I work with, we teach all over the UK. We've taught all over the place, and every time anyone runs a course, they are filled immediately. We get 200, 300 GPs. I moderate a Facebook group for doctors interested in menopause. There were 80 of us. There are now 6,000. So, and these are doctors who really, really want to help their patients. So what we would say, and what we often see in our clinics, is that women go and see a GP 2-3 years ago, they get rebuffed, they have a bad experience, and then they never go back. But what we would say is do go back. Look, the amount of learning, the amount of the things have changed over the last few years is huge. So please, I know how awful it is when you put yourself on the line and you go and make that appointment and you make yourself vulnerable and someone doesn't take you seriously. But actually, you often find, as Ginny said, that there is now someone in most practices who specialise in that. Sometimes a nurse, sometimes a doctor. So please, please, please go back to your NHS GP. If you can get an appointment, I know how difficult it is. I am an NHS GP. I know how difficult it is. But and just try, because things have really, really changed in the last few years.
And in the UK, you can also, some pharmacists are associated to the GP practices, and they can also prescribe HRT. And just make sure, first of all, don't be afraid to ask, and you're not alone. So, the symptoms that you may be experiencing, other women have exactly the same. And if the first time you're prescribed HRT doesn't fit you, it's not a one-size-fits-all. Go back and ask for advice how it could be tweaked, because often just a small change, it might be fantastic for you.
Should we get on to some questions?
Hi, thank you very much to you all. Question is, for example, if women were deterred from HRT when about 10 years ago, sorry, am I talking too quietly?
Sorry, they're not working.
Sorry, I can't hear. Just put the headphones on.
Can you guys hear me now?
Sorry.
That's all right.
Where do you switch it on?
White button. There we go.
Whoa.
Could
Is
you
that
repeat the
better?
question?
Yeah, I can hear. Yeah.
For women who were deterred from HRT about 10 years ago because of that research that was published, and they come to you in their 60s, for example, may or may not have had an osteoporotic fracture, would you start them on HRT now from a osteoporosis, bone density, cardiovascular point of view, or would you say you've kind of passed that time of commencing HRT?
Such a great question. Yeah. In case anybody didn't hear, this is if women 10 years ago got told, no, they can't have HRT, but it's 10 years since they've gone through menopause. Can they have HRT? Maybe Masood, will start with you.
I would probably look at the patient as a whole. What are the symptoms they're getting? We do know that in women with menopause, there can be a deterioration in bone density. HRT can be beneficial under those circumstances. But there are also other treatments available. Biphosphonates, calcium, vitamin D can be very helpful. So I think what I would do is assess the patient and tailor the treatment for that patient. HRT may be beneficial under those circumstances. I think what I would tend to do is make a decision as to what other symptoms they're getting. If they've got vasomotor symptoms as well, then HRT may well be a very suitable treatment for them. But I wouldn't necessarily just give HRT primarily as the primary reason to improve bone health. There are benefits there, but there's other drugs available as well. But it all really depends on the individual patient.
And Liz?
So I think this one is a tricky one to answer, because there's not a box standard answer to one. You have to see the patient as an individual. And so I would not like to give a general advice here. What you do have to consider, again, is coming back to the risks versus the benefits. And it's a very fine line. If a patient has 6 years or more past the final period, there is something what we call the window of opportunity. So if it's a long time past your final period, there's a slight increased risk of cardiovascular disease if you start with HRT. So that has to be balanced against the benefits that you get. So it is a very complex question, a good one, but it needs to be discussed with the patient.
Yeah, I just wanted to double down on what Liz was talking about. The risk here is around cardiovascular disease and atherosclerosis. And what we found out from the study that Masood was talking about, which is the Women's Health Initiative study, that in 2002 it broke and found that link between potentially breast cancer and some of the older forms of HRT that we don't use anymore. And as a result of that, 80% of women chuck their HRT in the bin, and doctors like us didn't get educated about menopause, and we're catching up now. It was not a bad study, and the study was actually designed to look at whether HRT could prevent cardiovascular disease in women, because in older studies from the 90s, they had found that women taking HRT for symptoms of menopause started in their 40s and 50s actually had less heart disease. The average age of women in that study was 63. And what we found is what we now call the timing hypothesis, which is that if you start HRT early enough, it prevents atherosclerosis and prevents heart disease. That's what it looks like. However, if you start it late, for some reason it's like it flips and it becomes potentially it advances atherosclerosis. And so at that 10-year mark, a lot of us were told, that's it, the drawbridge is closed, you can no longer have that. You now have reached the point where the benefits will not be outweighed by the risks. And these days we've come full circle where we are saying, this is your choice now. You need to know the risks, you need to know the benefits, and you need to make this choice based on your cardiovascular risk factors, including your blood pressure, your cholesterol, your family history of heart disease, whether or not you're a smoker, and how bad your symptoms are or how bad your bone health is. And now we put it over to you. So does that make sense? It was a really good question. Let's get your question.
Yeah, thanks. I read that you should be aiming for the lowest dose of HRT that manages your symptoms well. Is it ever okay to cut a patch in half?
Oh, this is great, Olivia. We're getting the best questions. You guys are awesome. I love this.
Yeah, no, I said the lowest dose to control your symptoms. I mean, that sort of makes sense, doesn't it? Unless, of course, you're using it for, and then it becomes slightly different when we're using it for things like bones. And so, but we cannot say it's safe to cut a patch in half because it's not licensed, but we do it all the time. So yeah, we do, and especially it's for people who are on things like, if you're on Everol Conti, which is a combined estrogen and progesterone patch. What we don't know if we cut it in half is whether there is enough progesterone to counteract the estrogen, what we were saying before, but actually it's something that we quite commonly do. But we would never say, yes, you can, it's not licensed, but we do it. Yeah.
Thank you. I'm afraid we're going to have to wrap everything up now.